Today, I'm going to discuss the management of a patient with unrepaired tetralogy of flow. Alice and I took care of her when she came in for a FES. I want to give a special shout out to Katie Banks, who I told that we would discuss this case, but then ran out of time. So she kind of inspired me to make this presentation for you guys. So the mnemonic I learned when I was taking step 1 for TET was PROV, so P-R-O-V. Primary defect is going to be the pulmonic atresia. So the degree of pulmonic atresia determines how severe everything else is. As you can imagine, worse pulmonic atresia is, the worse the RVH will be, the larger the aorta will have to be. So it's pretty important to note how atretic that RVOT is. In our patient, on multiple echoes and caths, they actually didn't see any blood flow through the pulmonic valve. So essentially worst case scenario. Next question you should be asking yourself is then, how is her blood getting oxygenated? What an excellent question. We'll get to that in just a sec. So one of the things you're going to get asked on your boards is a boot-shaped heart. So this is our patient's chest x-ray, and Alice was the one who mentioned that it was very boot-shaped. So just don't forget this when you guys take your boards. It's a very easy question for them to ask. All right, so back to blood flow to the lungs. Well, her lungs get blood from these aortopulmonary collaterals. So she developed blood vessels that come off her aorta that deliver deoxygenated blood to the lungs. As you can see, they are very large vessels because they grew with her from infancy. This is her only way to get blood to the lungs to get oxygenated. So you can see that all of these guys are, maybe I should have picked a different color than red, are abnormal blood flow, and those are those collaterals. So here we see these vessels again on CT. We'll pick a different color this time. It's pretty impressive, right? Okay, so now we know how blood goes from the LV. Remember, the RV doesn't pump anywhere to the lungs. But how does it get from the lungs to the body? Well, it returns to the heart in normal fashion through the pulmonary veins into the left atrium, back into the left ventricle, then out. So yeah, there is some recirculation because I just told you that the LV pumps blood into these aortopulmonary collaterals so that it may be oxygenated. So yes, it can be a redundant system, but we've got a few more things to talk about. What about the blood coming from the right side of the heart? How does it even get to the left side if the pulmonic system is atretic? Another great question. Boom, ASD and VSD. In this image, you can see both. So here's the ASD, here's the VSD. At the top of the image, you see the right atrium. So side note, for TTE on congenital patients, the image is always upside down. So right, you can see that this guy, the triangle is pointing down, and typically the triangle points up. That's how congenital echoes are done. I've never gotten a straight answer as to why they're done that way, but this is how they're done. So if you ever see what looks like a normal TT image but flipped, you can assume that it's a congenital echo. So this is an upside down view of an apical 4-chamber. And the reason I wanted to point this out is because you can see the ASD and VSD. So in this image, you can see blood flow through the ASD and the VSD, right? So blood flow through the ASD is there, blood flow through the VSD is here. I don't know if I'm dating myself with this background, but hopefully you get the joke. But anesthetic management is all about the VSD. You want the majority of the shunt to be left to right. You do this by maintaining an increased afterload. If you drop your afterload, you're going to get a right to left shunt, and then you'll be delivering hypoxic blood to the body. Obviously, you can't have your afterload be too high, or that will be too great of a strain on your left heart, but it's very important to keep your afterload high to maintain that left to right shunt. So what do we do? So we placed a pre-induction arterial catheter as to not drop preload during induction. We maintained a higher than normal map to make sure that we maintained that left to right shunt. So our maps were kind of close to 90 to 100 range, despite our patient being, I believe, in her early 30s. So there was a lot of thought and planning that went into this anesthetic. However, the vitals were pretty much train tracks. Patient did great, didn't have any issues, went to the PACU, went to the floor. So I think the big takeaways from this case are you have to maintain that left to right shunt. That's what everything depends on, is maintaining that left to right shunt. I left out some of the more tedious details of this talk because I know that your time is valuable, precious. You don't have tons of time to spend on learning. But if you want to hear more of the details, more about anything else about what considerations went into planning the anesthetic, feel free to grab me in the hall and we can make time and chat. But these are the big take-home points that I wanted you guys to have. So thanks so much for listening.